Today, I present to you doing as many Doctordle questions as I can in one stream until I get one wrong. A 24-year-old female patient presents to the ED with severe epigastric abdominal pain for the last 24 hours. So for the last 24 hours means that this is a pretty acute thing. Epigastric means that you're more like in the upper stomach area, centered around kind of like the middle lower part of the chest. So definitely not really area for appendix, not really the area for like ovarian cyst. Epigastric abdominal pain. So this could, again, it can literally be anything. In before something wild like Mallory-Weiss tear? No, you can literally go ahead. Mallory-Weiss syndrome, right? I mean, it's Doctordle. We'll eventually get it in 6, right? Like there's no shame in getting it wrong after the first or second one, right? So she reports that she recently started a new birth control and weight loss regimen. Okay, so now we're worried about kind of like drug-induced reactions, or weight loss regimen is another one too. So I guess with weight loss, I mean, this is just super out there, but weight loss, you're also thinking of things like mesenteric ischemia. There is a thing where patients lose the abdominal fat pad that's basically holding up the superior mesenteric artery, and once you lose that fat pad, you can get ischemia because your blood flow through that artery is impacted because the angle is too shallow. I don't know. I don't even know where to start with. So birth control and weight loss regimen, I'm kind of thinking like drug reactions, right? I mean, new birth control with new epigastric abdominal pain for the last 24 hours. Pancreas, right? Yeah, it could be. Birth control falls under, I guess it would fall under like the drugs section, right? So the full mnemonic for all the different causes of acute pancreatitis is I get PP smashed, right? So it's idiopathic, it's gallstones, it's ethanol, it's trauma, it's P being pancreas divasum, which is very stupid. The other P is going to be posterior duodenal ulcer. PP smashed. You're also going to have like scorpion sting, but the scorpion like only lives in like Trinidad or something. M is, oh crap, what's M? Oh yeah, mumps, right. That's how you know that I'm an internal medicine doctor, because I just like never encounter that. It's idiopathic, then gallstones, ethanol, trauma, posterior duodenal ulcer, pancreatitis divasum. S is steroids, M is mumps, A is autoimmune, S is the spider bite / scorpion stings, which I already talked about. H is hypertriglyceridemia. E is ERCP induced, which is like we do a procedure to take a look and that injures the pancreas. And then D is drugs. So all of this is to say, acute pancreatitis totally is in the differential. Honestly, pancreatitis could be a good one. The patient is tachycardic and hypertensive. Lab testing reveals mild hyponatremia. I'm thinking like a thyroid picture. I mean, there are very few things that make you tachy and hypertensive. Like, I'm thinking thyroid, maybe renal. Lab testing reveals mild hyponatremia, so I guess it's pointing more towards renal. But why would renal lead to epigastric abdominal pain? That's okay. Pain. Like the 6th clue is going to be like, patient also just got into a car accident. Actually, you know what? Scleroderma, renal, doesn't have it. This tacky hypertensive thing is throwing, so it's like, I'm thinking thyroid, but also hyponatremia kind of points more towards kidney, but epigastric abdominal pain doesn't really cover thyroid or kidney. So I'm not really sure. Acute intermittent porphyria, because it's last 24 hours. Actually, I mean, I guess porphyria kind of fits, because it's like a drug-induced reaction from probably her new birth control. She has a clot from the OCP causing bowel ischemia. That's why I wanted to put SMA syndrome. Like she has like a thrombosis and it's causing mesenteric ischemia. Should I put AIP? Oh my god. Acute intermittent porphyria. Like, it's not wrong. How the f did you get that? Wait, okay. So, while in the ED, the patient begins to exhibit paranoid delusions and agitation requiring mild sedation. Further questioning of the family reveals that several of the patient's relatives have had similar episodes. Then I probably would have gotten it on these two. And then the last one is really just screaming. A urine sample collected turns dark after standing, and testing reveals elevated porphobilinogen. AIP, I think it's in season 1 of House, I'm pretty sure. House's ex, right? The lawyer, and they have to like diagnose her new boyfriend, and like House is jealous of him or something, but he's also having like the acute like paranoias and delusions and agitations, and then they diagnose it by like collecting his urine and then like shining it up in like a window or something. But yeah, 45-year-old man presents with jaundice, abdominal pain, and fever. Okay, so we're working with gallbladder etiology, right? I mean, we're thinking we have backing up of the liver. We're thinking we have probably like bilirubinemia, something like choledocholithiasis. So this is when you have a blockage from the gallstone of the common bile duct. So not only are you having impaired bile secretions, but you're also blocking the bile ducts that come out of the liver as well. Right upper quadrant ultrasound reveals dilated bile ducts and intrahepatic cholestasis without cholelithiasis. So this is saying that they did an ultrasound, they took a look at the liver, the bile ducts are dilated, which means that there is something downstream that's blocking it, and intrahepatic cholestasis, which means that you do have like kind of biliary sludge sitting in there, without cholelithiasis, which means that there's no stones visualized in the gallbladder. But again, all of that actually kind of still fits into the picture of choledocholithiasis, because your blockage is in the common bile duct, which is way downstream, which means that everything else upstream is being blocked. And I put down choledocho, so now we have to think of other things that can cause dilated bile ducts and intrahepatic cholestasis that's not choledocholithiasis. What's the amoeba that makes like those liver paste cysts inside the liver? You know what I'm talking about? And I was thinking, if you have one of those cysts and it's blocking up the ducts from the inside too. And Entamoeba histolytica, yes, Entamoeba histolytica, right? So you have these like stupid, okay. Lab testing reveals mildly elevated AST, ALT, elevated ALP, and eosinophilia. And anytime you see eosinophilia, you have to think about parasites. And I think somebody also said this in the chat, Chlornorchis sinensis, Chinese liver fluke, very famously has an eosinophilic reaction. There we go. He reports that he recently traveled to East Asia for an exotic fishing experience. As you can tell, Chinese liver fluke is probably endemic to China. Stool examination reveals oval-shaped operculated eggs. Operculated is such a good word. I would not know what to do with that at all. I probably knew that at one point, like second year of med school. Yeah, praziquantel is just like antiparasitic. We would use praziquantel and, you know, drugs like albendazole. Other things you've probably heard about are like ivermectin, right? And these really help you get rid of parasitic helminth infections. Honestly, if my Entamoeba one was right, I would have gotten it in 2. That would have been so cool. But eosinophilia, definitely, you know, red flag for parasites right there. 68-year-old man presents with sudden onset severe abdominal pain. Maybe we can do appendicitis. He's a little old, you know, for his appendix to rupture, but it happens. Appendicitis. Aww. All right. He has a history of AFib, but denies any recent trauma or surgery. Oh, wait. This one's definitely mesenteric ischemia. Yeah. Okay. So infrequent, painful bowel movements, abdominal tenderness, pretty elevated lactate level that's showing that tissue is dying, leukocytosis, probably reactive from inflammation, and then the CT angio reveals an occlusion in the superior mesenteric artery. So this one just straight up tells you like, oh, his superior mesenteric artery is blocked, and you're just supposed to be like, yeah, it's mesenteric ischemia, duh. 34-year-old man presents with fatigue, shortness of breath, and jaundice. I'm just gonna say hepatopulmonary syndrome. That's a good one. They don't have hepatopulmonary syndrome. Congestive hepatopathy, maybe? All right, so let's say congestive heart failure causing congestive hepatopathy, reversal of flow. He's having right-sided heart failure leading to the shortness of breath, and congestive hepatopathy leading to the jaundice. Okay, it wasn't that. Ooh, wait, Cut 555 says alpha-1 antitrypsin deficiency. So A1AT actually does explain, you know, the wheezing and the hepatomegaly, because it's the elastase damage, right? You would differentiate it from COPD based on if the like atelectasis is like pan-acinar versus lobar or something. I don't remember. Actually, you know, A1AT kind of fits because it's lung and liver. Alpha-1 antitrypsin deficiency. Is this another one where it's like I get it right in 2 and I get it right in 2 and it's a little sus? Here we go. Yeah, the pan-acinar ones. There we go. Okay. Causes emphysema in 30-year-olds with no history. Yeah, so I was here, mild wheezing on lung auscultation. Then you're starting to look at obstructive lung disease. But why would you have obstructive lung disease with hepatomegaly? Poor reversibility with bronchodilators means that it's not asthma and you're thinking more of a COPD. And if you're thinking COPD with liver, then that's probably going to be A1AT deficiency. So I think definitely doable at 3. 2 is excellent. 3 doable. 4 doesn't really tell you anything, but 5 showing pan-acinar emphysema predominantly affecting the lower lobes. I mean, that's literally what I was talking about, like the lobar versus pan-acinar involvement. So definitely you should be getting it in 5 because it's screaming at you at that point. So this is also where I remind everybody that I'm an internal medicine hospitalist. All right. There is going to be a lot of times where I am probably going to run into a peds or an OB-GYN question on Doctordle, and we will just have to deal with it. I don't know, man. We might end the stream here. I mean, 9-year-olds, poor school performance. I mean, it could be ADHD, right? Because they're just like they're too active and oh my God. Okay. IQ testing results are within normal ranges and he forgets to turn in his assignments. I think I could have gotten this at 3. I don't know. Poor school performance is actually like you're probably thinking like ADHD, right? Because it's not like, it's probably not an intellectual disability problem. It's more just like they can't focus kind of problem. So poor school performance, actually, I think I remember from like my board prep last year, poor school performance, yes, this guy's 9 years old, but I think there's like another one for like 3-year-olds or 4-year-olds. If they present with these similar symptoms, like they forget to turn in their assignments or like they can't wait or like talk out of turn, actually, sometimes it's just because they're too young. You know, like in America, like our school year is like September to June, right? And which means that kids born in the summer usually get bumped to the next grade. But sometimes, you know, if you have a kid in kindergarten, right, who's 4 years old or 5 years old and like they can't follow directions properly, or like they're having trouble learning letters, sometimes it's basically just because they're like younger than they should be for school, right? So it's like you're treating a kid born in July like the same as a kid born in September the last year, right? And that's almost like a whole year of development difference. So it's sometimes really just the age difference when you are that young that like makes it harder to learn in like a classroom environment. 52-year-old woman presents with persistent night sweats over the past several weeks. Okay, so we're thinking B symptoms, cancers, night sweats, I don't know, lymphomas, lymphoma. Probably not primary testicular lymphoma in a 52-year-old woman. We do like Hodgkin lymphoma, maybe? No. She smoked cigarettes since the age of 18 and reports having a chronic cough for the past year. So I'm going to say small cell lung cancer. I mean, persistent night sweats is such a non-specific B symptom, like fevers, night sweats, weight loss, all these things. Mucus producing and occasionally streaked with blood. Honestly, night sweats and cough streaked with blood, I am kind of thinking more like TB actually. Let's just say TB. Tuberculosis. Oh, it was TB. Okay, nice. She has not seen a doctor in several years. She recently emigrated from Mexico along with a group of laborers to work in the United States. A chest x-ray reveals cavitary lesions in the upper lobes of the lungs. So yeah, once cavitary lesions in the upper lobes of the lungs is not entirely pathognomonic for TB, but TB cavitates, which means it makes its own little pockets, and it goes to the upper lobes of the lungs because TB is a aerophile. It likes oxygen, so it wants to stay in those highly oxygenated zones in the lungs. Sputum staining is positive for acid-fast bacilli because TB, like the bacteria, stains positive on that specific, what is it, like PAS test or whatever. Yeah. 55-year-old man presents with chest pain, fever, and difficulty swallowing since his esophageal surgery 4 days ago. Ooh, bad. Okay, so he had an esophageal surgery and like now he's got an infection. So esophageal surgery, I'm not sure if it was like a Nissen or something, but I would say like esophageal perforation, right? Borhave syndrome, definitely got to think about this when you have like chronic alcoholics or people who vomit a lot. That can blow up the esophageal lining and start leaking out into the mediastinum. On exam, he appears ill, is tachycardic and tachypnic, and has diffuse anterior chest tenderness. Is this just mediastinitis? Oh my god, it is. All right, I would have gotten that in one. I mean, like, yeah. So chest pain, fever, and difficulty swallowing. You're worried about an esophageal pathology causing like a rupture of that system. Like rupture, blow up, right? If you vomit enough or have enough increased pressure in that system, you can really tear the esophageal lining in half. And when that happens, all those contents are going to start leaking out into your mediastinum, which is that chest wall space, and you start going to have infective contents spill out there as well. Maybe he had some injury from his surgery, or he had some, weakness from that surgery, and then all of a sudden things started spilling out, and now he's got a full-on infection in the mediastinum. 55-year-old man presents with left lower quadrant abdominal pain, fever, and nausea. So left lower quadrant's pretty interesting. There's not usually that much going on there, right? Like right upper, you're thinking liver, gallbladder. Left upper, you're thinking stomach. Epigastric, maybe you're thinking pancreas. Right lower, you're thinking appendix. Left lower is really just your sigmoid colon, which is the part that's connecting your descending colon to your anus. So it's sigmoid because it's like S-shaped and it kind of curves around from the left side of your abdomen down towards your rectum. Popular spot for diverticulitis. Diverticulosis is a common thing that happens in a lot of older adults. Imagine your colon is like a balloon inside of a net. And when you blow up that balloon, you have these little outpouchings that are going through the net. That's essentially what, straining is against like your mesenteric plexus, like all the muscles and the nerves around that area in the colon. So over 50 years of using your colon and straining and having bowel movements, you can develop these little outpouchings. And when these outpouchings get, like food, or like peanuts is a really bad one, blocking those little outpouchings, then you end up, or not peanuts, sorry, popcorns. When you get something like food or like popcorn blocking those little outpouchings, they can get infected and lead to diverticulitis, which kind of leads to like this crampy abdominal pain with this infection. You're not completely pooping out blood, but usually what ends up happening is that you get GI to end up doing an emergent scope and they're just like, oh, it's just diverticulitis. And you're like, oh. I hope it's diverticulitis, because this is a pretty good presentation for it, yeah. So there's a very wide differential for left lower quadrant pain, but diverticulitis is actually a pretty common reason for why people come in here. Physical exams revealed tenderness in the left lower quadrant with guarding, but no rebound tenderness. So, I mean, it's got like diffuse kind of pain, but it's really on the left lower quadrant where you're feeling tender around there. But without any rebound tenderness, I mean, it's not like something is immediately dying, right? Labs revealing leukocytosis and a digital rectal exam is unremarkable. Labs revealing leukocytosis says that he's got a white blood cell count that's elevated, probably because they're fighting off the infection and the inflammation going on. CT shows thickening of the sigmoid colon with surrounding fat stranding. Yeah, so there is inflammation going on there. No evidence of abscess formation or perforation, so you're not worried about it, blowing open, causing a connection from the gut and the rest of the pelvic cavity. You're not worried about an abscess or like a severe infection like that. And like I said, you manage this pretty conservatively just with antibiotics and fluids. So he's managed with oral antibiotics and a clear liquid diet, and he gets better. 70-year-old woman presents with itchy blisters on her arms, leg, and abdomen. Okay, so blisters, Blisters are pretty specific. So there are only 2 blistering diseases, right? Like you're worried about bullous pemphigoid or pemphigus vulgaris, right? Like again, think about this from like a med student level, right? Like it's either PV or BP, and you would basically differentiate those based on the Nikolsky sign, which is you scrape it away with your fingers, and if it scrapes away, it's one of them, and if the other doesn't scrape away, it's the other one. One of them is like a basement membrane problem. The other one is like a gap junction problem. Are gap junctions different from connexins? Are connexins different from desmosomes? I don't know. These are just like random histology, dermatology buzzwords in my brain. Dude, I'm not a dermatologist. I don't remember. Let's just say pemphigus vulgaris. Me. All right, it's the other one. She reports that the blisters have been present for several days and are tense and not easily ruptured, so it's bullous pemphigoid. If it's not bullous pemphigoid, I'm gonna end the stream. I don't care. Okay. 34-year-old woman presents with fatigue, pallor, and exertional dyspnea over the past several months. I mean, at the risk of being stereotypical, it's anemia. 34-year-old woman probably has iron deficiency anemia. Am I sexist? No, I'm not. All right. So it was the pallor that made me think of anemia, right? So fatigue and exertional dyspnea could be a lot of things. You're thinking cardiovascular, you're thinking lungs, you're thinking like for a young woman, things like pulmonary arterial hypertension or whatever. But pallor, like having paler skin, right? Probably because you're anemic, probably because you don't have enough hemoglobin going around your system. That's probably why. Heavy menstrual bleeding and occasional pica. I mean, pica from the iron deficiency means you start eating things that have no nutritional value because your body is so starved for nutritional value in iron. A lot of times you'll see people like chewing on ice and stuff. Conjunctival pallor, spoon-shaped nails, all these things happen. Microcytic hypochromic anemia, so small pale red blood cells. Low ferritin because their iron stores are low, and elevated TIBC because when your stores are low, your capacity to bind iron is high. Anisocytosis and poikilocytosis. Anisocytosis is just saying that you have red blood cells of all different shapes and sizes, and some of them are tiny and spiky because obviously red blood cells aren't being produced properly here because you lack iron. So yeah, we give them iron and they got better. 60-year-old woman presents with abnormal uterine bleeding. Okay, this could literally be anything. All right, we were just talking about it, so let's just say endo. Abnormal uterine bleeding means a lot of things. It can mean like bleeding outside of your normal cycle. Oh wait, she's 60. Hang on, she's 60. So she should be postmenopausal. So now we're worried more about like a cancer workup, right? So I mean, like endometrial carcinoma. I mean, like an ovarian carcinoma. It's not lupus. Name a uterine cancer. Uterine carcinoma. There we go. Endometrial carcinoma. There we go. I would believe it. Ultrasound reveals a solid ovarian mass. Oh my god. All right. What are the solid ovarian tumors? There's like sex cord stromal tumor, but I remember doing that one with Bree, so it can't be sex cord stromal tumor. There's a theca tumor, sex cord thecoma, ovarian theca lutein cyst, sex cord granulosa cell tumor. Dude, it could be any of these. Granulosa cell. Oh no, I don't know. Oh no. Second question is already saying that she has a solid ovarian mass. So now we're just like running through like all the different ovarian cancers that I know. It's one of these like solid ovarian tumors. I just don't know how to differentiate. Oh wait, okay. I was gonna say I just don't know how to differentiate between all of them. I think histology of the ovary shows lipid-laden stromal cells. This one is probably pathognomonic for sex cord thecoma, right? So a thecoma is a tumor of the thecal cells. The granulosa cell tumor is a tumor of the granulosa cells. This benign sex cord stromal tumor is identified as a cause of the patient's endometrial hyperplasia. Why is that written like a Jeopardy question? So this one's like what is sex cord thecoma? But yeah, I mean, histologically, I wouldn't know how to differentiate between a granulosa cell tumor and a sex cord thecoma. So if lipid-laden stromal cells means anything to you, congrats. You're either a pathologist, a second-year med student, or a gigantic nerd. 45-year-old man presents with several weeks of subtle clumsiness and occasional trouble finding the right words. Subtle? What does subtle clumsiness even mean? Okay. Occasional trouble finding the right words, I mean, makes me think of more like a stroke pathology, right? Like we're worried about like vertebrobasilar insufficiency, maybe like TIAs. I don't vertebro insufficiency. Do they even have it? No, they don't have it. Maybe like carotid stenosis. Oh, they don't have carotid stenosis? Wow, okay. Let's see. Like hypoplastic basilar artery, that's not one either. Ooh, huh. Subtle clumsiness is more like an ataxia, so like cerebellar involvement. And then occasional trouble finding the right words is middle cerebral artery involvement, right? So that's Broca's, that's word finding difficulty. Like subtle clumsiness, I'm not really sure if that's ataxia or not. It's just like I don't know. Like what is subtle clumsiness? I've literally never heard something described as subtle clumsiness before. If I choose to believe subtle clumsiness is ataxia, how are you going to get a middle cerebral artery and a posterior cerebellar artery pathology at the same time? What about a demyelinating pathology? I mean, I guess it could always be multiple sclerosis. Oh no. He denies fever or recent illness, but reports that his symptoms have been slowly worsening. Is it ever something viral like PML? It could be, but I mean, PML, you need to be like a kidney transplant recipient or like pretty advanced HIV with a low CD4 count to be like immunosuppressed. Like BK virus, JC virus, like they don't just occur in like normal 45-year-old people. Brain tumor, yeah, I mean, you want to go glioma? We can do glioma or oligodendroglioma. No? Oh my God. On neurologic exam, he has mild right-sided weakness and expressive aphasia. Okay, so expressive aphasia, it means he can't get out the right word. So, I mean, this doesn't really change anything. So he has right-sided weakness and expressive aphasia. So he's got right side symptoms from the left side of the brain and then non-dominant hemisphere affecting Broca's. So, like, try PML. I mean, do you have lesions reaching around PML? Like lesions reaching around from the cerebrum to the cerebellum? Oh my God, how did you get that? Okay, hang on. Like 4, his medical history is notable for untreated HIV with a CD4 count of 45. Like I literally said like you would only see this in like an HIV patient that is like completely immunocompromised. Like I don't think you can get like JC virus or BK virus if you have a CD4 count above 50. So like 45 is like pretty bad. Okay, like definitely I could have gotten it at 4, but I feel like getting it at 3 is a little sus. I mean, this probably points you towards it, and then this multiple asymmetric non-enhancing white matter lesions without surrounding edema. I mean, that's just like the definition of PML right there. 45-year-old woman presents with heavy, painful periods. Uterine fibroids, it could be endo. Chronic pelvic pain and dyspareunia. I mean, we can go leiomyoma, fibroids. Here, physical exam reveals a uniformly enlarged uterus. So leiomyoma is, just an overgrowth of the smooth muscle layer of the uterus. So usually in that case, the uterus has more of like a lumpy appearance because it's more just like little random outpouchings of that smooth muscle growth. Actually, yeah, if I said endo, I probably also should have said adeno. Oh, nice. Okay, yeah. So, okay. So, I mean, I think if you said endo, you probably could have said adeno after. So definitely these two, probably doable. Uniformly enlarged is just pointing you away from leiomyoma. Ultrasound shows multiple areas of shadowing, which is basically just going back to the 6th question. So it's endo, but it's growing inside the muscle layer. So that's where you're going to get adenomyosis from. A 62-year-old woman is found to have vague abdominal discomfort during a routine checkup. I mean, we already did diverticulitis, but very, very common presentation. IBS you wouldn't really see in a 62-year-old woman, but sure. All right. Physical exam is unremarkable, but adnexal fullness is, oh my God, it's an OB-GYN question. Adnexal fullness is noted on bimanual exam. All right, so we're back to ovarian cysts again. Seriously? Ovarian corpus luteal cyst, ovarian follicular cyst, ovarian theca lutein cyst. I don't know, man. Oh God, I know. What other masses are there, dude? I don't know. Are we worried about cysts? Serous cystadenoma. I don't know. Like, why wouldn't it be? Okay, I feel like you looked that up. How did you get serous cystadenoma before this third one? How did you? Like, I mean, all right, chat. My eye is on you. Clearly, you guys just want me to keep going. 6-year-old girl presents with small flesh-colored bumps on her trunk and arms that have been present for 3 weeks. Oops, back to peds. I mean, small flesh-colored bumps for 3 weeks. I mean, that's like molluscum like pox virus, right? Like that's just like what it is, right? All right, good. All right. I remember something from peds, guys. Yeah, so I mean, pox virus is a big fat virus. Monkeypox, if you remember, that was a thing. Remember when monkeypox was a thing? They're just really big viruses that live on the skin. They cause like inclusion bodies, I think. It's not that important. It goes away. Like, yeah, she is advised on hygiene practices to reduce the spread and to monitor for spontaneous resolution. Yeah. 6-7-year-old man presents with difficulty urinating and nocturia. Okay. So difficulty urinating and nocturia. First things you're worried about in an older man is BPH. So benign prostatic hyperplasia. The prostate gland is an enlarged gland. Okay, I got it right. The prostate gland is a little walnut-sized gland that like sits in between the bladder and like the urethra. It kind of controls the open gates, if you will, for the urethra. So one way allows urine to flow through the urethra and out the penis. The other way allows, sperm and seminal fluid and semen to flow out of the penis. Not really flow, but you know what I mean. It enlarges with age, enlarges the testosterone exposure. So BPH is a very common thing that affects older men. And an enlarged prostate starts pressing on your bladder, starts giving you these symptoms where you feel like you need to urinate at night or you don't fully empty. And yeah, so weak stream, sensation of incomplete bladder emptying. That's definitely what I just said. Monogamous with a spouse of 42 years and denies any history of sexually transmitted infections. So prostatitis is definitely another possible thing. Prostatitis usually is associated with STIs. But obviously this guy, there were 2 of them that just said he has no infection. So no dysuria, hematuria, or fever. You're not really thinking about a UTI or prostatitis either. Digital rectal exam. This is what we do rectal exams for. All right. Not only to look for poop, but to actually feel the prostate. And if the prostate is small and normal, or large and boggy, or smooth, non-tender, or like hard and spiky, like those all mean different things. So, benign enlargement, prostatitis, prostate cancer, etc., etc. 35-year-old man presents with swelling in his legs and occasional headaches. He reports feeling more fatigued over the last few months. Okay, so we've got, I don't know, it could be like any nephrotic thing. Let's type in nephrotic. So we've got membranous nephropathy, could be, diabetic glomerular nephropathy, could be, we got Berger, we've got membranous nephropathy, we've got focal segmental glomerulosclerosis, elevated blood pressure, and bilateral lower extremity edema. FSGS, yeah, I think blood pressure is more of like an FSGS picture. Okay, cool. Yeah. 3+ protein. So he has a history of obesity and long-standing hypertension, but no known diabetes or autoimmune disease. So, I mean, the kidneys are going to be the ones bearing the brunt of that. And he's also on heart for HIV and has a history of heroin use. That is pretty on the nose. I feel like directly on Pathoma, it says that FSGS is associated with IV drug use and HIV. And then the 6th question says kidney biopsy, says segmental glomerulosclerosis and hyalinosis with some glomeruli with focal foot process effacement on electron microscopy. So, I mean, yeah, it really says it's focal segmental glomerular Sclerosis. Yeah. I mean, it was this one definitely was pointing towards a nephrotic syndrome. So, I mean, if you just went down the list of nephrotic syndromes, you probably could have gotten FSGS. A 55-year-old man presents for a routine exam with no complaints. What the f am I supposed to do with this? How is this a diagnosis? What the f do I do with this? How are you supposed to do this? I mean, maybe it's like something that like you wouldn't like discover, right? Like maybe it's like lung cancer, right? And it's just like you don't like what it's like adenocarcinoma, right? Like he has no complaints on his routine exam, but then you like 6 months later, he like shows up for like a scan and gets, you know, found out to have lung cancer. Dude, what the f is this? His history includes well-controlled hypertension and he takes lisinopril. So he's fine. Dude, what the f is this? Diabetes? Sure, dude, I don't, what is this? Oh my God. Physical exam is unremarkable with a heart rate of 60. First degree AV block, right? First degree AV block is just asymptomatic bradycardia, right? Like sinus brady, and then you just deal with it. Oh my God, that was so stupid. What the f? Why didn't you intro with this? Why did you give 2 lame clues? These weren't even clues. These were just statements. Bro, he just wants to see you. So, brief loss of consciousness while shopping for groceries. I mean, we could just say vasovagal syncope. Wow, they don't have any kinds of syncope? Vasovagal syncope? No? Hello? Orthostatic hypotension after the patient stood up from the bottom shelf to grab wheat bread. All right, that's a good one. Right, he got the Mr. Krabs, he got dizzy, and then he fell over. No, okay. He reports a feeling of lightheadedness before the episode, but no chest pain or palpitations. Lightheadedness, so I'm thinking like blood pressure, blood flow problem. Like, dude, why isn't carotid stenosis a thing? Carotid sinus hypersensitivity. This one's a good one. This one's usually like if they're wearing like a tie or something and then they pass out. Oh, yeah, so carotid sinus hypersensitivity, it's like the blood pressure receptors on, you know, the carotid bodies are too sensitive, right? So any sort of stimulation around them. So yeah, you either find it with like people who wear like really tight ties, or he was turning his head to the side to look for an item on a high shelf. So that position that he put himself in, where he was turning his head to the side, was compressing his carotid sinus, and that's how he ended up passing out. Yeah. During evaluation, gentle pressure applied to the right side of the neck reproduces the symptoms and results in transient bradycardia. Yeah, so this is what you're actually supposed to do to diagnose carotid sinus hypersensitivity in the office. Remember to only do this on one side. Do not try to do this to both carotid bodies at once, because that would be very bad. A 28-year-old woman presents with a painless bump on the dorsal side of her wrist. Ganglion cyst? I mean, it just has to be a ganglion cyst, right? Like, what else could this possibly be? Like, this isn't even like a Doctordle question. This is just like, do you know what this is? 44-year-old man presents with recurrent upper abdominal pain and diarrhea. I mean, it could be like pancreatic insufficiency, maybe. That could be a good one. IBD? Yeah. Treated multiple times for peptic ulcer disease, but his symptoms return quickly after standard therapy. It makes like, it keeps making ulcers, tumors. What's it called? Zollinger-Ellison syndrome. There we go. Yeah, so this one is literally just like you have, oh, it's also associated with Men1, but you basically just have like this condition that causes you to make a bunch of ulcers, and like you really just have to give them as many PPIs as possible. 35-year-old man presents to the ED with seizures and headaches that began 2 weeks ago. So he's only had seizures for 2 weeks. That's crazy. So yeah, like a brain tumor can cause seizures, but like 2 weeks ago. So you're worried about like maybe like an infectious growth. So I'm worried about like maybe it's another HIV patient, right? Maybe it's like toxoplasmosis. So Toxoplasma gondii can go to the brain, cause these lesions. He has no prior history of seizures or neurological symptoms, and he takes no medications. So again, it's probably just telling you this is like an acute thing that happened 2 weeks ago. This is probably an infection. It's not toxoplasmosis. What else goes to the brain? We already said PML for another one, so I don't think it would be PML. Didn't I make a post about Taenia solium? Like neurocystic curcosis. Oh, it is neurocystic curcosis. Okay. Neurocystic curcosis is Taenia solium, the pork tapeworm. It's the one that you get from eating undercooked pork. This one can go to the brain and start causing these cystic lesions. And anytime you have something growing in the brain or bleeding in the brain or pushing on the brain or just anything being in that brain space where only there's supposed to be brain and you have something else going on in there, it's going to cause different neurological deficits. And in this case, it's pushing on something and it's causing seizures. And headaches too. But again, it only began 2 weeks ago, right? So obviously this wasn't something that he's born with. You probably wouldn't have like a full-blown like meningioma or, you know, a glioblastoma manifest in 2 weeks. So this is probably an infectious source. Taenia solium causing neurocystic glucosis, probably because he had, you know, he recently immigrated from Central America where he was an agricultural worker. So he probably was exposed to it over there. All right, 32-year-old man presents with a 2-day history of malaise and agitation. Okay, malaise and agitation. So he's lethargic. What? Malaise and agitation. So he's just not feeling well, feeling crummy, and he's agitated. I don't know, meningitis? He reports recent symptoms of sweating, rhinorrhea, abdominal cramps, diarrhea, and okay. Well, I mean, they literally just listed all of the symptoms of opioid withdrawal. Oh my god. Physical exam reveals dilated pupils, lacrimation, and piloerection. So that's dilated pupils, tearing, and like hair on the end of the skin is standing up. Heart rate, BP are elevated, temp is elevated, symptoms improve with supportive care, including antiemetics like Zofran and fluids. And he reports recently stopping heroin. So this is why you don't, you know, instantly try to quit opioids cold turkey, because this is, you know, a very real thing that happens to patients. When you're trying to taper off of opioid or, you know, substance use disorders, I mean, we try to get patients into methadone clinics or give them a medication called Suboxone, which is a combined buprenorphine medication, and it's a partial agonist in this case, and it kind of helps patients ease off of, you know, having all of these opioids in their system. So they're not going from 100 to 0, you know, they're being gently weaned off. 65-year-old man with dementia presents with a 2-day history of fever following an elective cholecystectomy. Okay, 2-day history of fever following an elective cholecystectomy. So you're thinking of post-op fever, right? So it's water, wind, wabscess, walking, wonder drugs. So 2-day history, I mean you could just have an infection, right? Like a hospital acquired infection, some kind of nosocomial infection. 2-day history of fever following an elective cholecystectomy. I mean, what is post-op fever? Is it wind water wabscess or water wind wabscess? I think it's wind water wabscess. So you're thinking about like urinary tract infection. I don't know why Doctordle specifies that it has to be an E. coli infection. What? Dude, I was so close. All right, urinary tract infection. So it is wind water wabscess, walking, wonder drugs. Those are the 5 W's of post-op fever. I don't remember that much from my surgical rotation, but I remember that much. During the procedure, he had a Foley catheter placed and complains of continued urinary discomfort. I don't get it. How's it not a UTI? It's literally a UTI. He had a Foley placed during the procedure and has had 2 days of fever since then. What the hell? Oh, you know what this is? This is Enterococcus faecalis. That is so stupid. That is so stupid. Because Doctordle only has E. coli UTI. Doctordle only has E. coli UTI as a UTI thing. So for Enterococcus, you have to say enterococcal infection. Okay, Enterococcus faecalis is a gram-positive bacteria that grows in the biliary tree, and it also can grow in the urinary tract. 25-year-old woman presents with a firm, irregular breast lump. Phyllodes tumor. She was recently the restrained passenger in a motor vehicle accident. I mean, we were just talking about pancreatitis and trauma being one. So breast fat necrosis, I think, is probably the answer. Yeah. So when a patient is sitting in a car and you're wearing your seatbelt and you suddenly have that immediate trauma to that area, you can actually like cause the fat to basically burst essentially and saponify. And that trauma is enough to basically set off this necrotic reaction where more dying cells are going to chain react and cause more dying cells and everything. So these microcalcifications and these lipid-laden macrophages and necrotic adipose tissue is just more breakdown of breast tissue and the macrophages that are trying to clean the space up. But yeah, fat necrosis from trauma, definitely a real thing. It's essentially the same thing for pancreatitis. You would get the pancreatic fat necrosis from trauma like a seatbelt as well. All right, that one was pretty straightforward. For a firm irregular breast lump, the fact that they give you motor vehicle accident in the second one, I feel like that could have been a lot worse. A 29-year-old man presents with rectal discomfort and a sensation of incomplete evacuation. Okay. Internal hemorrhoids. Internal hemorrhoid is a good one, right? Because if they're pooping and they're feeling it kind of like plopping around in the rectum, intermittent tenesmus and mild rectal bleeding for the past 2 weeks. I feel like that's still valid for internal hemorrhoid. I feel like because external hemorrhoids are painful and it's discomfort and sensation of incomplete evacuation, right? It's not exactly painful. A lot of people overlook proctitis. That's a good one. Oh, okay, it was proctitis. All right, there we go. The patient reports, I've noticed a slimy or sticky coating on my stool. He denies weight loss, but reports recent receptive anal intercourse without condom use. So, I mean, flexible sigmoidoscopy shows erythematous, friable mucosa limited to the rectum. So it's all, you know, happening in the mucosal layers in that area. It doesn't go any higher, but it's not going any lower. So you're basically just having a local infection. 76-year-old man presents with persistent back pain and fatigue, progressively worsening over the past several months. Back pain and fatigue, I mean, there's so many things. I don't know, like back pain and fatigue, like degenerative joint disease or something. I mean, he's old, right? Degenerative joint. They don't have anything. Lumbar disc herniation, maybe. I mean, that's not really pain. It's more like sciatica, but Laboratory studies reveal a hemoglobin hematocrit of 10 and a serum calcium of 12.1. Okay, so now I'm thinking more like multiple myeloma. There we go. All right. So elevated serum calcium, it's one of the crab signs of multiple myeloma. Multiple myeloma is it's a cancer of the B cells in your bloodstream, like the cells that produce antibodies. And basically you're going to have a growth of these cells where they just start producing out a bunch of junk antibodies, and that clogs up your kidneys, causes kidney damage. You're going to have these lesions in your bones, and it's going to spike your calcium levels. And you diagnose this by trying to find a spike of immunoglobulins. So this is what the serum protein electrophoresis, the SPEP, and the UPEP end up doing together. They help you identify which antibody line is being overproduced here. 58-year-old woman presents with non-specific pelvic discomfort. All right, dude, this could be so many things. I told you I was gonna go out on a gynecology question. All right, so I guess we can start with ovarian cyst, maybe. A firm adnexal mass is palpated on pelvic examination. That is literally how all of the other gynecology ovarian cyst questions started. Ovarian, well, if it's not a corpus luteal cyst, maybe it's a theca lutean cyst. Oh my god. Pelvic ultrasound demonstrates a small, solid hypoechoic ovarian lesion. Oh my god. All right, well, if it's not a corpus luteal cyst and it's not a theca lutean cyst, then maybe it's an ovarian follicular cyst. God damn it, what the f- How many different ovarian cysts are there? She denies weight loss, early satiety, or bloating. Okay, so it's a cyst. It's not a cancer. All right, it's probably not a tubo-ovarian abscess because she's not coming in with fever, so it doesn't look like a sign of infection. Serous cystadenoma, mucinous cystadenoma, dermoid cyst. Oh my god, mature cystic teratoma. Oh my god, it could be any of these. I think we already did serous cystadenoma for one, right? Okay, so dermoid cyst and mature cystic teratoma are basically the same thing, right? Like, isn't a teratoma a type of dermoid cyst? Oh god, I don't know any of this. Dermoid cyst. Histology reveals nests of epithelial cells with grooved coffee bean nuclei. I have no idea what that means. I feel like if you're a pathologist or an OB-GYN, like, you probably instantly know what this means. I've no clue what this is, guys. Coffee bean nuclei? cyst. I guess serous cyst adenoma or mucinous cyst adenoma wouldn't have coffee bean nuclei. I feel like a mature like a teratoma does not have coffee bean nuclei. I genuinely don't know what coffee bean nuclei is. Well, it's nests of epithelial cells. Is nests of epithelial cells going to be a cancer? Why is there no cancer? Ovarian cancer. Why carcinoma? All right, here we go. Me. Choriocarcinoma. No, it's an ovarian lesion. Mucinous carcinoma, serous carcinoma, renal cell, mucoepidermoid carcinoma. I don't know. I think it's time for bed, guys. I don't have a good answer. Mucoepidermoid, right? Because it's got epithelial cells. Mucoepidermoid makes sense. These cells resemble transitional epithelium, and the excised tumor demonstrates benign features. What? So it's not a it's benign. So it's what? But transitional epithelium should not exist in the ovary. So this is a tumor. It's metaplasia turning the ovarian tissue into a transitional epithelial tissue. Transitional epithelium is like the bladder, right? So it's something that can stretch, and the cells in there can like stretch and squash, which, you know, for the bladder, because it expands and, you know, retracts as you have more urine and expel urine, it's fine. But like, obviously you don't want your ovary cells turning into transitional epithelium. I mean, it's not cancer, it's metaplasia, but it's like ovarian metaplasia an answer? Oh my god. All right, I think it's donezo. I think we lost. I don't even know what this is. Like, again, I'm sure if you're a pathologist or OB-GYN, you see coffee bean nuclei and transitional epithelium, and that just like instantly means something to you. But this is meaningless to me. All right. Mucoepidermoid. What was the other one? Serous cystadenoma. Serous. So it's transitional epithelium. I don't know. Game over. The diagnosis was Brenner tumor. What the is a Brenner tumor? I don't know what this is. A Brenner tumor is an uncommon, predominantly benign type of ovarian surface stromal tumor. Okay, fine. Give me some histology. All right, well, so nests of epithelial cells with bean nuclei. Oh my god. Well, I mean, when you put it like that, yeah, it makes sense. Benign but sometimes malignant ovarian Brenner tumor named after Fitz Brenner. Some of the nuclei have a longitudinal groove similar to the groove found in a coffee bean. It was good while it lasted. We tried. We were finally defeated. No.